Hey everyone, I have a new video for you tonight. Let's get into it. We have a 64-year-old man with type 2 diabetes and hypertension. He's brought to the ED because of confusion and diaphoresis. His wife reports that he recently started a new medication after an MI 2 weeks ago. His current medication regimen is listed out right here. He's diaphoretic, he's confused, afebrile, normotensive, slightly bradycardic, respiration's good. His glucose level is 38, so he's hypoglycemic. And the question is asking which of the following best explains why this patient did not experience his usual warning symptoms prior to this episode. So in this video, I want to cover two big concepts as far as step 2 questions go. Number one is reading what the actual question is asking, okay? And once we get into these answer choices, you'll see what I'm talking about. Number two is looking at what the question stem is giving you, okay? One important strategy that I used for my step 2 was basically just looking at what was taking up most of the question. Where is NBME trying to focus their attention on? Where do they want you to look? Over here, this piece of information, his wife reports that he recently started a new medication, and then they give you his full medication regimen. Guys, these two sentences, this is almost half of the stem of the question, which means off the bat, without even reading these answer choices, I know the diagnosis is going to do something with these meds, okay? They're not talking about his past medical history as much. They just mention the diabetes and they continue on. They're not talking about labs. They're not emphasizing his vital signs. Guys, this is a big portion of the stem, so we're going to focus our mainly on here, okay? So the diagnosis, first of all, he has low glycemic hypoglycemia. He's not having his usual symptoms. The answer is masked hypoglycemia, okay? Masked hypoglycemia, okay? That's the answer. And what causes this is the beta blocker. Remember, he had an MI 2 weeks ago. He was probably started on the beta blocker. He's a diabetic. He takes insulin. Guys, he takes insulin, so he probably gave himself an extra dose of insulin or so, not realizing that his usual symptoms of hypoglycemia, and then that probably just tanked his glucose levels. And so let's start off with E, decreased cortisol secretion. This is incorrect. This would be in a person with adrenal insufficiency, Addison disease. This would, the question stem would focus a lot more on his past medical history. It would focus on, hypotension, symptoms of weight loss, lab abnormalities, and we don't see any of that here. Reduced hypothalamic autonomic activation. This could be a cause of hypoglycemia, but it is not the case here because, once again, they mention the type 2 diabetes, but they don't really, mention that this patient is having peripheral neuropathies. They don't mention the extent of the diabetes. They don't even mention his A1C. And so to assume the diabetes is causing nerve damage, which leads to decreased sensation of, the blood glucose levels, sending it to the brain, we can't just assume that. So we're going to take that off. Like I said, guys, very simple. Focus on what the question is giving you. They're giving you a good portion of the medication. They list out all his medications. It's going to be a medication problem. C, increased insulin sensitivity in peripheral tissues. Now, this could be an answer. Okay, this could cause hypoglycemia. Increased insulin sensitivity essentially means insulin works better. So, it's a very strong, potent molecule that will cause peripheral tissues to take up glucose a lot, leading to hypoglycemia. Compare this with insulin resistance, where the insulin is trash and it just doesn't work, okay? The problem with this answer is it doesn't actually answer the question. The question is asking, why doesn't he have his usual symptoms? This is giving you a cause of hypoglycemia that could be unrelated. So we're going to cross that out. Impaired hepatic glycogenolysis. Once again, this could be caused by beta blockers, mainly non-cardioselective beta blockers. So this guy's on metoprolol. It's a cardioselective, meaning it's only going to work on the heart and the kidneys. But let's say they did give us a non-cardioselective beta blocker and, impaired hepatic glycogenolysis. This would explain why his body's not responding to the hypoglycemia. This would explain why his liver is not releasing glucose to make this level go up. But once again, this doesn't explain the symptoms. The actual symptoms is being caused by a decreased epinephrine-mediated cardiac stimulation. What does that mean, guys? It means the heart has beta-1 receptors. Beta-1 receptors normally, they lead to tachycardia, increased heart rate, okay? They lead to increased heart rate, increased contractility, and they cause the heart to basically go into a sympathetic drive. When you're blocking this with a beta blocker, with metoprolol, and you're blocking this, you're essentially decreasing the heart rate, you're decreasing the contractility, you're letting the heart take a rest. And so normally what happens in hypoglycemia is we get these warning symptoms. Hypoglycemia leads to release of epinephrine. This epinephrine normally binds to beta 1, which leads to tachycardia, and then the patient can feel palpitations. They can sense that they're going hypoglycemic, and so maybe they'll eat a chocolate bar or something. So this patient obviously wasn't having those symptoms, and he probably gave himself an extra insulin dose and leading to decreased glucose levels, but he's not having the palpitations, he's not having the normal symptoms because the beta blocker is blocking the epinephrine from binding to these beta 1 receptors. And so that's masked hypoglycemia. It's a quick concept I wanted to talk about and cover today. We have a couple of more quick rapid fire questions about beta blockers. 66-year-old man, type 2 diabetes, insulin. Oh, and the other thing is masked hypoglycemia, guys. As far as NBME goes, it's always going to be in a diabetic who's on insulin. These two plus a beta blocker means they're going to probably ask about masked hypoglycemia, okay? Masked hypoglycemia, I'm not going to spell it out. But they're not going to ask you masked hypoglycemia, just in general. Someone's on a beta blocker and then they come in. They're always going to mention he's a type 2 diabetic and he takes insulin. So keep these three in mind. The other thing I wanted to talk about really quickly was how do beta blockers, people say they cause hypoglycemia and that they cause hyperglycemia. So as far as the hypoglycemia goes, guys, it explains, in a person who is susceptible to hypoglycemia, which is always going to be the diabetics plus insulin. Someone who is susceptible to becoming hypoglycemic for some reason, and then that can become worsened by the beta blockers because there's decreased hepatic glycogenolysis. The liver can't compensate and increase blood glucose. And so that leads to worsening of the hypoglycemia. When it comes to the hyperglycemia, what insulin normally does to what beta 2 receptors usually do is they increase insulin secretion, and that insulin secretion is going to decrease blood glucose levels. So when you have a beta blocker, specifically a non-cardioselective beta blocker, that is going to actually cause less insulin release, which means there's going to be increased glucose in the blood. This is a chronic process. Okay, so when it comes to hypoglycemia versus hyperglycemia and beta blockers, hypoglycemia is going to be in the acute setting in a patient who has a specific reason to be hypoglycemic. When it comes to the hyperglycemia, it's just going to be a chronic process. So what mechanism explains why he did not feel the symptoms? We already went over this. It is a lack of sympathetic activity in the heart. Which hypoglycemia symptom is preserved? The patients are usually preserved is diaphoresis. They're usually sweating. Well, if you were to use propranolol instead, what additional metabolic effect might have occurred? This answer right here is going to be bronchoconstriction. Metabolic effect is going to be, like we said earlier, decreased insulin release, which leads to hyperglycemia. That is caused by beta 2 blockade. This patient also had asthma with the propranolol. What adverse effect would you worry about? Bronchoconstriction. If he abruptly stopped the medication, he would have rebound tachycardia, rebound hypertension. And this is actually a low yield fact, but like I said, my channel is really for people who want to score in the 260 plus. Someone who's on a beta blocker and he suddenly stops the beta blocker, this can cause an MI. Okay, this is very important to know, because what the beta blocker does is it puts the heart to rest. It's suppressing the heart rate, it's suppressing the contractility. When you suddenly remove it, so we have, this is the beta blocker right here, okay? Beta blocker, this is the receptor. When you suddenly remove the beta blocker, you have epinephrine, it's going to attack this receptor like crazy, and it's going to cause the heart to increase contractility, increase heart rate, go in overdrive mode, and that overdrive mode can lead to coronary perfusion imbalances leading to an MI. Okay, so just a small little pearl there. And then next up we have 54-year-old man, cocaine-associated chest pain, given IV metoprolol in the ED. His chest pain is worsened and blood pressure rises. What is the mechanism? This is caused by unopposed alpha vasoconstriction. There's alpha receptors And then beta receptors, alpha causes vasoconstriction, beta receptors cause vasodilation in certain parts of the body. And so when you have a beta blocker that comes and occupies this, you have epinephrine or cocaine. This is going to just all bind on the alpha receptors. It would try to bind the beta block on the beta receptors, but it's blocked by the beta blocker, so it all goes to the alpha receptors, causing vasoconstriction, which leads to worsening blood pressure. And then if the patient later develops bradycardia and hypertension, what is the antidote? This is glucagon. And then quickly, last two questions. 60-year-old man with HFrEF, stable in clinic, started on metope. 3 days later, he presents with acute pulmonary edema and hypotension. So the question is, why should beta blockers not be started in decompensated heart failure? Because the heart is already struggling to contract and pump blood. If you put a beta blocker, you're going to even make it worse and a crappier pump, and it's not going to perfuse the tissues. Which 3 beta blockers improve mortality in HFrEF? Metoprolol, bisoprolol, and carvedilol. If this patient had symptomatic bradycardia, what would that represent? This is a contraindication for beta blockers. If a patient comes in, they have AV blockade, they have symptomatic bradycardia symptoms, you do not put them on a beta blocker because once again, it blocks the AV node. That leads to a decreased heart rate, and it can even worsen the symptoms of bradycardia. And then which receptor mediates renin release? This is beta 1. Beta 1 is present on the kidneys and the heart, and then beta 2 is present on the other tissues. Mainly, think of lung, think of skeletal muscle tissues, and then think of blood vessels for beta 2. We have a 29-year-old woman with migraine headaches. She started on propranolol. She develops fatigue and cold extremities. What receptor explains the cold extremities? This is going to be beta 2 receptors. This is why in patients who take non-cardioselective beta blockers, they can end up with Raynaud phenomena because the blockade causes vasoconstriction in those extremities, and it leads to cold extremities and worsening symptoms. And then spasms usually too. Why can propranolol worsen depression symptoms? Well, propranolol has some central beta blockade, and that can lead to some, psychiatric issues there. Which receptor in adipose tissue is blocked with propranolol? Beta 3. Okay, beta 3, the main thing to know about this is when you block it, it leads to weight gain. So beta blockers cause weight gain by blocking beta 3 receptors because this prevents adipose tissues from breaking down fat. And then what is the role of propranolol in thyroid storm? This, one of the side effects is that it decreases T4 to T3 conversion. So this decreases the thyroid available, and then at the same time it decreases the heart rate and it, used for rate control. And that's it.